When Mary told me about this meeting and said, can you come and meet the guys and have a chat with them? And she said, choose a subject. And I don't know whether you've heard about the subject. I decided to talk to you today about, yes, prostate cancer, but I decided to be a little bit controversial for a change. So I called my little talk tonight Controversies around prostate cancer. You all, by virtue of being here are quite knowledgeable about prostate cancer to a much higher degree than the general public, either by chance or by desire, I don't know. One of the things that are worrying me about the world we live in now, not just prostate cancer, is something called misinformation. And I don't know when the word were coined, but it probably isn't that long after Trump got in power in the States. But I'm sure misinformation have been around for a very, very long time in human history. And I want you to just think for a second how easy it is to put everything in a box and leave it there, job done. And it's not all that people who propagate misinformation are doing it because they are bad people. I think the vast majority of them are actually good people, but they found that the problem is so complicated, they wanted to work their way around it. So they came up with simple answers for complex problems. And there isn't a simple answer for a complex problem, but they couldn't cope with the complexity of the problem, so they decided they'll make it simple so everybody can understand. And I think that's a little bit harsh, because sometimes, certainly in the medical profession, subconsciously you think you know best, but you don't. So if we take surgical practice, I'm a surgeon, urological surgeon at that, but I'm a surgeon. Until today, 90% of all surgical treatments that we practice on a daily basis has absolutely no evidence behind it. Now, evidence is different levels of evidence. Again, we, as a profession, scientists, doctors, statisticians, like to simplify things that are by nature complex. So say evidence, grade 1 evidence, grade 2, grade 3, grade 4, okay? So grade 4 is to listen to somebody like me who thinks of himself as an expert and says, in my opinion. An advice, once you hear somebody saying, in my opinion, stop hearing him or her. It means that they're just gonna say anything without any evidence. And that's why we say expert opinion is level 4 evidence. It's the lowest level of evidence. But then you go up a notch to level 3 evidence, where there are people like me and my colleagues gather some information over the years following patients that they have treated and see who did well and who did bad. And then they present this series of patients and results. And they say this is evidence. It is evidence, but it is a weak evidence because it's based on a series of patients. God knows how you collected them. God knows whether you only told us about the ones that did well and you didn't tell us about the ones that didn't do well. So that's a weak evidence. You go up a notch to level 2 evidence, whereby you compare in a prospective randomized way two groups of patients who had treatments, different treatments. One group had one treatment, the other group had another treatment, but these patients are chosen in a way that they are representative of all the patients, and they have the same disease with the same degree, and they are of the same age, they have the same kind of comorbidities or other health issues, and then you treat them like one was radiotherapy and one was surgery, and then prospectively you do that, and you would then compare the outcome after 10 years and see who did better and who did worse. So that's level 2 evidence. Level 1 evidence is the highest level of evidence in which different groups of clinicians from different parts of the country, from different parts of the world, did the same experiment on different groups of patients in a prospective randomized controlled trial. And each trial obviously will have slightly different outcomes to the other trial. And then you analyze all of these trials together in a way that we call systematic review and meta-analysis. So then we've got a higher level of confidence that the recommendation at the end of this meta-analysis is the nearest you can have to the truth. So this is the highest level of evidence. But here lies in the problem. When we say surgery for appendix, it's very simple. Inflame the appendix, you make a little cut, you cut the appendix out, and that's it. There would be very little, if any, variation in doing this operation between one surgeon to another, between one hospital to another, or one country to another. Because it's a very simple procedure. You're gonna cut your toenail. You're gonna cut your appendix out. You're gonna cut your gallbladder out. But there are other procedures, like cutting the prostate out, or cutting the bladder out, which are very complicated procedures, that when two surgeons do the same operation, they are never the same, even though we call it prostatectomy. They are never the same quality. How much margin you left, how much nerves you preserved, how many lymph nodes you removed, how much blood loss happened, how many of your patients are continent after the operation, how many are not, how many are potent again, or how many are not, how many had recurrence of the disease, and how many didn't. All of that are not only dependent outcomes, not only dependent on the patient characteristics, whether he was fat or slim, whether he had diabetes or not, whether he had hypertension or not, whether he had erection problems before or not, but also dependent on the disease characteristic. Was the disease low-risk disease, Gleason 6 or 7? You all probably know about what I'm talking about. Or was it a very high-risk disease, Gleason 9 or 8 or 10? And obviously the skills of the surgical team. Because of that, it's extremely difficult, if not impossible, to have a straightforward, simple answer for such complex problems. And that's why when we all are listening and reading in the Daily Mail and reading in the British Medical Journal and listening to somebody like me talking, it's very important to look at the evidence we're looking at, like somebody who is using the evidence for enlightenment, and look at it with a critical eye. Don't look at the evidence like a drunken Irishman uses the lamppost for support rather than for enlightenment. Sorry for anybody Irish here. So reading the literature, whether it's in the common press, whether it is in the hospital leaflet that we give you, whether it's on the website of the Royal College of Surgeons, whether it's listening to NICE, and don't start me on NICE, I will mention it once or twice. You have to exercise your brain power and sift through what you're reading. It's not complicated. Common sense will guide you. Once somebody says, oh, 100% of my patients are continent after this operation, immediately know that he's lying. Once somebody says, all my patients are cured, he's lying. That's common sense. You need to listen to honest people, honest accounts, acknowledging the complexity of the problem, and acknowledging that 90% of what we do does not have level 1 evidence, and then exercise your judgment, and it is a judgment call. And if you do it empowered by as much knowledge as you can, you'll get it right most of the time, but sometimes you'll get it wrong. And this is life. Until such a time when we know everything, we are guessing, educated guess based on level 1, 2, 3, 4 evidence, based on personal experience, based on what happened to my neighbor who went to Wolverhampton and had the operation. My other neighbor went to Worcester and had the operation, and see what happened to them. It's all anecdotal evidence. It's not a very high degree of evidence, but this is what we've got. Decisions about treating patients presenting today have to be taken today. We can't wait another 20 years when we have better quality evidence. It will be too late for them. And that's fine, so long as both us as healthcare professionals and you as patients and relatives and friends are aware of this complexity, aware of these pitfalls, and find your way around it. So let's talk about evidence and controversies in prostate cancer. Until a few years ago, about 2022, I think it was, December 2022, there's a group called Prostate Cancer Risk Management Group, which is part of Prostate Cancer UK, the big charity. And this group is a group of scientists, statisticians, and doctors. And I've been in this country now 30 years. Ever since I arrived, this group used to look at all this evidence in the worldwide literature about PSA and at what level you should alert the man you should go and get checked. And they used to look at all the level 1, 2, 3, 4 evidence, exclude the studies that are not reputable, and very independently will come with their conclusion after the meta-analysis they do. And initially, and Mary will remember that, they used to tell us if PSA is above 7, you're worried about the man and he needs to get checked. After a few years, more evidence accumulated, and then they said, no, it's actually 6. Okay, that's based on the best evidence available to them then. So we all followed them. Then a few more years, and more studies came out, and they said, no, it's 4. It's PSA of 4. We followed them again. The government of the United Kingdom at this time, and I'm talking now late 80s, 90s, early 2000s, up until 2022, until the pandemic actually, so a bit before 22. The government realized that this group of scientists and statisticians, A, are independent, B, have no conflict of interest, and they are very good at what they do. So they mandated, the government of the day mandated that we follow their advice, and we followed their advice. It made sense. But then came the pandemic. Before the pandemic, a couple of years before the pandemic, the same group said, actually, we found more evidence, and they showed the evidence, and we need to be a little bit more circumspect about that. So, they dropped the level to 3. And initially they said 3 if you are in your 50s, and 4 if you are in your 60s, and 7 if you are in your 80s. And we carried on with that for a few years, and then they decided this is so confusing to the GPs and to the clinicians and to the patients, and a bit age discriminatory if we're honest. So they made it 3 across the board until the age of 75, I think, and then above that you go up to 6 or 7. And we followed them. But then the government found the pandemic, hospitals got overwhelmed, lots of doctors left after the pandemic and after Brexit. So we are in a pickle. We can't cope with the workload. So what do? They get NICE to give its opinion. And here's what makes me very angry. NICE didn't actually look at any new information. There was no new information out in the worldwide literature. They looked at the same data that these guys from Prostate Cancer UK analyzed, but they kept doing like the Irishman, using the literature and the information and the data to support what they already wanted to do, rather than to use this literature and this wealth of data for enlightenment to try to guide us to what is best according to our current knowledge. So the way to do it is to exclude some studies from the analysis. And they put some ridiculous exclusions. And then they came up with this new cutoff, which is 4.5. So we're going at 3 for everybody below the age of 70 or 75. They made it up to 4.5. And that's until the age of 60. Above 60, it would go to 5 or 6, and above 70, it would go to 7 or 8. Hang on, what are we doing here? And they calculated by doing that, we reduced the referrals by so much. And we achieved the targets better, because we're not achieving the targets. You know, the 2-week target and the 4-week target and that. And they said, by the way, this is a guidance. You don't have to follow it. It's not a law. But they say that for every NICE guidance, this is a guidance. But dare you not follow NICE guidance in the NHS, you're slaughtered as a clinician. By the way, we're not following it, and we're being slaughtered, and we're happy with that. So we kept telling them, this is wrong. Every day in my working life, I diagnose young people with very aggressive prostate cancer, and their PSA is 3.2. Very aggressive to the extent that it's probably not curable. So you're telling me, don't start to look into him, and you're telling the GP, don't refer him unless his PSA is 4.5. So wait another year with a very aggressive disease festering in him because you're worried about your waiting times in hospitals. This is, I'm not going to use a strong word, but it doesn't sit easily with me. And here is the problem. All of us are very, very busy. We're working day and night and weekends to try and cope with the workload, and we're not coping. So for some humble urologist like myself to sit down and read 654 pages of dry information and statistics, which is the underpinning evidence for NICE guidance, And believe you me, I sat a whole weekend and studied it in December 2022 when it came out, because I couldn't believe what I'm seeing. And I spelled out in my analysis the flaws in NICE analysis. And I tried to go and criticize NICE or challenge NICE, that's the right word. Oh, they said, okay, but NICE used this group of people analyzing. They are professors of statistics and professors of public health. I found not a single urologist in them. There was one urologist from Cambridge, and all the rest are lay people, statisticians, professors of something or other. But they're not clinicians. They're not the ones that are seeing, like I do or my colleagues do, these people who are at their prime, their late 50s, early 50s, at their prime, very productive, very valued members of our society, that we are proposing not to look into them and to dissuade GPs from testing them and referring them because it doesn't comply with NICE. So I went to a friend of mine who's a professor of statistics. I said, right, we need to do something about it. I showed you where the flaws in their methodology is. I want you to get me 2 statisticians from your department to sit down, analyze the data properly now, and produce a paper to criticize NICE and challenge it. He said, yeah, you're absolutely right. I can see where you're coming from. It's very obvious, but I will need 4 statisticians to work full-time for 6 months on this piece of work. So can you pay them for 6 months full-time? Because my university is not going to fund it. So couldn't fund it. Went to something called Cancer Alliance. There was a big boss in the Cancer Alliance. I don't know what they do, but anyway, I was a big boss and tried. They said, no, we follow NICE. Who are we to challenge NICE? Okay. Went and met the National Cancer Czar, professor of oncology in Southampton. Said, yeah, I can hear what you're saying, but this is NICE. Yeah. He said, okay, we'll see what we can do. But I can't promise anything. Okay. And this is how things are happening in the country at the moment. There's a professor called Professor Moore in UCL in London. A lovely lady. I know her very well. She happens to have looked at it in some detail, and she completely agreed with every word I say. So she said to the Cancer Czar and to the NHS, look, this is nonsense, we're not following it. So UCL still doesn't follow it until today. Worcester doesn't follow it, everywhere else they do. There is a couple of other trusts in the country who don't follow it. But even after Professor Moore said that, they said, okay, we will have to go back to NICE and negotiate with them. And that was about a year ago. Until now, I don't think what's happening in NICE. And I don't know whether NICE will budge or not. So this is just to, not to make you lose confidence in the system. The mere fact that people like me and like Professor Moore and the other groups are challenging the system, are not following NICE guidance to detriment to our sanity and our careers, but we're doing it because it's to the best interest of our patients. We are collecting data prospectively now. We have been for over a year, of loads and loads of patients who have low PSA, much lower than NICE guidance, who we diagnose with very serious prostate cancer and we treat them. Long story short, don't be fobbed. Be assertive and polite. I don't envy the GPs. My colleagues in urology, specialists, don't know what to do. And most of them say, oh, avoid the headache and follow NICE. You can't go wrong by following NICE, even in court of law, which is true. If something goes wrong, and you go in a court of law and say, but I followed NICE guidance, no problem. But nice guidance is wrong. Well, that's not our problem. So, if you are below the age of 70 and your PSA is above 3, you need to be checked out. That's it. Again, NICE tells the GPs, oh, when the patient asks you, don't do the PSA as routine test. Don't. The GPs can be ticked off if they do it as a routine test. Okay. You only do it if the patient asks. And if the patient asks, warn him, hey, if you do it, you might not like the result. Okay, we know that. That's the whole point of doing it. That if there is something that we don't like, we know about it in good time and do something about it. So where is the controversy here? But that's what GPs are told. So I feel sorry for the GPs. I don't want you to feel sorry for the GPs, but when the GP says, yeah, but, you say, oh, but NICE says, if the patient is well informed and wants to have a PSA, you can't tell him no. So if the GP tries to tell you, no, don't have the PSA, no. I know, NICE says, and the NHS says, if the patient is well informed, and I am well informed, I know that nasty Mr. Makar's team are going to put needles in my prostate if my PSA is high and put me through the horrible investigations and treatments they do. But I want to know it, because guess what? Every Friday afternoon, which is our multidisciplinary team meeting, we have 1 or 2 patients, not in their 60s, not in their 70s, in their 40s and 50s, presenting with metastatic disease that has already spread all over their body, that is not curable. And the only reason why they're presenting like that is because we don't have a national screening program for prostate cancer. Not only we don't have a national screening program, but we're dissuading men from being checked. So don't be fobbed off. Go and have your PSA checked if you haven't. If it's good, it's good. If it's bad, at least we know and deal with it. If you don't want to, nobody is going to force you to have it. We have a screening program for breast cancer for God knows how many decades, and for cervical cancer. Nobody goes and pulls the woman from her kitchen. You're going to have a mammogram today. No. It's just available to you. If you want it, you have it. If you don't, you are a mature adult. You can do what you want. That's fine. But at least you know it's available. We all get that letter in the post with the little box and put a bit of poo here and send it in the post. And some of us don't want to do it and throw it in the bin. Nobody will know. They won't send the bailiffs to say, where is your letter? So we're not forcing anybody to have anything that he or she doesn't want to have, but we're making it available to them if they want to have it. The other thing is, if I am black, or if I have 2 or 3 members of my family, even if I'm white, who had prostate cancer, my chances of getting prostate cancer are twice as much as the average man in this country. So the average man, the typical man in this country, has a 1 in 8 chance of getting prostate cancer. But if you are of a black Afro-Caribbean ethnicity, or if your family has 2 members or more with prostate cancer and or breast cancer on the women's side, you're twice as much likely to have the disease. So rather than 1 in 8, it's 1 in 4. So it's a very common disease. The good news is it's very treatable. Only if you discover it in good time, you'll be cured. If you discover it late, even if you discover it late, you will achieve good remission, as we call it, for years and years to come. And every few weeks I go to read a new article or to go to review a study to be published or go to a scientific meeting anywhere in the world. Every few weeks there is a new treatment coming out. It's a fantastic time for prostate cancer and kidney cancer for all that matter, because we started to understand it a much bit better than what it was 20 years ago. So today, as we speak, 20%, 1 in 5 of all men presenting with prostate cancer in this country are presenting too late, after it has spread. It shouldn't be like that. There's huge regional variation, and as you would expect it, it varies depending on the socioeconomic class. So if you're well educated and have the means and have the time to pay attention to your health, you will get checked and you won't be fobbed by the GP, and you will have your PSA done and you'll get detected early, and then you will be detected before it spreads. If you are poor socioeconomic class, not very well educated, not well spoken, frightened of going to the GP, frightened of meeting a police officer on the beat, because people are like that. Then once the GP says no, it's no, okay, thank you, and you go home. And that's not fair. That's absolutely not fair. Worcestershire actually does quite well. So we have a much lower incidence of metastatic disease at presentation than inner city areas in Birmingham, for instance. It's a huge disaster there. We're lucky because our GPs as well are like-minded. Most of them are very good GPs. Most of them listen to us, talking to them like we're talking to you now. And most of them are brave enough to challenge dogma of NICE or Royal Colleges or something like that. So I'm very satisfied with the way it is in Worcestershire. The other thing is this group, not least because of Mary's contribution over the years and decades, has raised the awareness in Worcestershire as an area of this disease. And we have a much better position. We are in a much better position. Now this is the diagnosis. Let's go to the other controversy, because I'm not going to hold you long. The other controversy is treatment. And so it's a minefield. It's an absolute I have no idea how patients can choose a treatment unless they are like those people who like simple answers for complex problems, cope with it mentally, go for it. And fair enough, if that's the way you are, that's fine. And that might be okay if you're buying a car or a shed for the garden. But if you're going to have something as fundamental as treatment for a condition like this that could have serious effects on your quality of life and your length of life, you probably should be a little bit more circumspect and a little bit more inquisitive about what you're going to have. And when you Google it or look at the BAUS website or NICE or any tool or available to you or hospital leaflet, you'll find they're trying to be fair. And again, I go back to what I said before, they're not bad people. They're just misguided. They think there are simple answers to complex questions. They're trying to give you everything. Or you can have surgery, robotics, open. They don't say open now. They abolished it completely. Radiotherapy, brachytherapy, HIFO, cryo, God knows what. Hang on. Why? To give all the information, confuse people, when you know, as a healthcare professional, that if you have a T3, i.e. locally advanced disease, Gleason 8 or 9 or 10, i.e. very high risk, and the PSA of 10 or more, this is the extremely high risk disease that to start to talk about HIFO or cryofocal therapy, brachytherapy, or robotic surgery is a waste of time. None of that will touch the wall. I'll give you statistics from our own practice here. We recently, as in Christmas, just gone, looked at, again, we were criticized, and I think Paul Rajaban spoke to you some time ago, we were criticized, why on earth are you still doing open prostatectomy? Nobody else in the country does it. I said, yeah, but they are wrong. Yeah, it can't be Worcestershire is the only right place. Okay, let's look at the data. Because rather than having a narrative account of what's going on, which is all what is there, a narrative account, oh, have Rory the robot, we've got Rory the robot, thank you to your help. Have Rory the robot doing the operation for you, you'll go home the day before the operation, and you'll never have any complication. I challenge you, and there's a good number of you here, to go back and spend about 6 months searching the whole world literature, not only the UK literature, for any long-term oncological outcome of robotic surgery. It does not exist. Nobody is brave enough to publish their data, to the extent that they're not collecting it, because you best hide it under the carpet. To the extent that they do the operation and they never see the patient afterwards. They call it PIFU nowadays. Do you know what PIFU is? Patient-initiated follow-up. I have no idea what that means. But it means that you see them once after the operation. Oh, great. You've done great. Okay, off you go. No more appointments, but it's an open appointment for 2 years. If you have a problem, you phone us and we'll see you, and good luck with that. What? We know that prostate cancer, when it will recur after a few years from the operation or a few years from the radiotherapy. So fobbing the patients, essentially that's what they're saying, and go, you're good. I find the patient 2-3 years after the operation hasn't had a single PSA. A relative of mine had his robotic prostatectomy in London about 4 or 5 years ago. It was 2020, so it's 4 years ago. And I met him in a wedding not long ago. I said, okay, how's your PSA? I said, I don't know. Well, he said, okay, what was your surgical margins from the operation? I don't know. Did they remove any lymph nodes? I don't know. And the bloke that I'm talking about is an ITU specialist in cardiology. I said, so you had the operation privately in a big hospital in London. He doesn't know what operation he had. He knows that it was with a robot. He doesn't know for 4 years after the operation whether his PSA is recurring or not. I said, so how did that happen? He said, well, Mr. Such and Such. I said, well done, you've done very well, consider it cured, and that's it. I've never seen him again. Here in Worcestershire, Mary started with me in 2007 an intelligent database called the Survivorship Scheme. We have thousands of patients on it now. Every single patient, 2 years after we followed them in the clinic, after they finished either the surgery or the radiotherapy, we never discharge them. They go on an intelligent web-based database. They have 2 CNSs. When Mary was with us, was only 1 because she works like 2. And 2 CNSs in constant touch with them, phone, text, emails. Make sure that they're having their PSA whenever it's due. Make sure that the database is done in a way that if the PSA is higher than what you would accept for this patient, so it's personalized for every patient, a red alert will go, so the nurse will put on the computer in the morning 2-3 red alerts out of the few thousand patients. She will dig them out, she will come and discuss them with me. Everyone has a plan. Nobody gets missed. The patients on it since 2007 until now.
And they keep coming to me, commissioners and hospital bosses and whatever, when are you going to discharge them for survivorship? I said, they are being discharged when they die. Yeah, when they die, they die. That's it. I can't do anything about it afterwards. And I think so far we had 600 who died, and none of them died from prostate cancer. This is the next point. The way, that's what we did in December and showed everybody and shut them up, hopefully forever, but I doubt it. So we showed them, they decided to bring external review of our services because we are an outlier. We're still doing open prostatectomy when 97% of prostatectomies in the country are done with the robot. We had already started with the robot. Currently, by the way, we're doing 65% with the robot and 35% with open. So they brought a couple of big guns from Bristol to review our practice. And when they came, they stayed, I think, about 4 weeks to review the practice and look at the data. They were gobsmacked. They couldn't believe it. They said, we can't criticize them. Yeah, they do open, but they have results unrivaled. So they left us and they went. So because they brought the blokes from Bristol to review our results, I said to my understudy, okay, go and collect our results for the last 20 years. Put them on a spreadsheet, because the results are there in the databases, just extract them. There is a paper came out from Bristol about 18 months ago about their results with robotic surgery for high-risk cancer. They are showcasing the good work they're doing. Okay. I said to him, I don't want to be involved in this process. You've got the external reviewers. You go and collect our results, statistically analyze them, and compare them with the same group of patients from Bristol, from the bosses coming to review us. So, okay. And then ship it over to the reviewers. And that's why they never came back again. And I'll give you the bottom line. The bottom line is, for high and extremely high risk prostate cancer, that's tumor gone outside the gland, or PSA above 20, or Gleason 8, 9, and 10. We do what is called multimodal treatment. So we tell them, this is a very high-risk disease. It might not be cured, but we'll do our best. We'll start off with open surgery, deep clean, the word I use, taking all the lymph nodes out and what have you. Robotic surgery is not going to be any good for you. And if there is recurrence in the future, we can give radiotherapy, chemotherapy, hormonal therapy, what have you. We keep this thing suppressed until you die from another reason. And this is what they found. They found is in Bristol, when they treat this patient, group of patients with robotic prostatectomy, and they looked at them 10 years later. They looked at them immediately after the operation, immediately, as in the next 2-3 weeks. They found that 50% of them have residual PSA. The PSA did not disappear after the operation. 50%, 1 in 2. And by 5 years, 75% had PSA recurrence. And by 10 years, 100% had PSA recurrence. 100% had recurrence. Our series was 100% had no PSA after the operation, rather than 50%. And at 10 years, only 40% had PSA recurrence from the highest risk group. Compare the 40% to 100%. The news are even better than that. We didn't only look at PSA recurrence. We looked at those who had recurrence in metastatic disease in the bone, in the lung, in the liver, and we found that 72% did not have any metastasis after 10 years. This is the highest risk group. 72% did not develop metastasis. And then we looked at death. That's the ultimate goal, isn't it? We found the following. By the way, we looked at all groups, not only the highest risk. We find almost nobody died from the cancer in risk group 1, 2, and 3. So anything up to Gleason score 7, nobody died from the cancer in the first 10 years. And then risk group 4, which is the lesser of the high risk, 4 and 5 are the high risk, 5 is the highest. Risk group 4, we found something like 10% died from the disease after 10 years. So 9 out of 10 did not die from the disease. And risk group 5, the highest of the risks, only 30% died from the disease after 10 years. So even the highest risk, which 100% of them recurred in Bristol, after 10 years, we had 70% still alive and kicking and don't have disease. When they saw the data, they just disappeared. You have to take again this data with a pinch of salt, because it was not a randomized, controlled, prospective trial. So it's not level 1 evidence. But I kept challenging all the people, certainly from Birmingham, not from Bristol, over the years. When before the robot came on, the vogue then was keyhole, which is an awful operation. They used to do it in Birmingham. And keyhole with the robot is a much better operation. But keyhole with your hands is just an awful operation. It's not being done at all now. But I kept challenging them. Let's do a prospective randomized control trial. Every 2 patients come. You have one in Birmingham, do him keyhole, and I have one in Worcester, do him open. And then compare the results at 5 and 10 years. They refused because they knew that they are not honest. And that's why they stopped doing it. So what's the situation now? If you go anywhere else in the country, there are big bosses and professors and sirs and lords, and I'm very happy for good luck to them. Go and have your operation done anyway, it doesn't matter, so long as it's a decent surgeon or half a decent surgeon, and so long as your disease is low risk or intermediate risk. If your disease is high risk, do not accept this. You either have proper surgery with extended lymphadenectomy, which all guidelines in the world say you should have, which can only be done with open surgery, although, and I've got news for you, I started trying to do the extended lymphadenectomy with the robot with some degree of success, but still not as good as the open one. And the reason why they don't do it, 90% of all prostatectomies in this country today are done without a single lymph node removed, because it's done with the robot. And if you try to remove the lymph nodes with the robot, it takes at least 2 more hours in the operating theater per patient, and you expose the patient to more risks of bleeding and having to repair blood vessels and having to repair this and that. And you have to have a superb knowledge of the anatomy, and you have to be a very experienced surgeon. So it's not reproducible. There are a handful of very experienced surgeons in Europe and in America, and it's only a handful that can do it with the robot. I think we've made inroads here in Worcestershire. We are selecting some patients because we counsel the patients very well. You have high risk, not you. You have high risk. I think you'll do better with open surgery, but if you want robotic, I will do it. But you have to accept that it's not going to be as clean a surgery as open surgery. You may go home 1 night or 2 nights earlier. You may go back on the golf course 1 or 2 weeks earlier. But certainly by 10 years, you will have recurrence, 100% chance of recurrence. And this chance is 40% if you have it open. It's your choice. I can't make your mind up. I can inform you of our state of the knowledge now, and you choose. And if you choose, and some patients do, typically the patient will be 79 or 80, say, Mr. Makar, I had a good inning. I don't want to have a big operation. If the robotic is a bit gentler, do the robotic, and if I have recurrence in 10 years, I will be somewhere else. So I go along with it, and I do it with the robot, and we're having some success, but it's too early to see whether it will be as successful in preventing the cancer recurrence or not. So don't be fobbed that it's either robot or the highway. No, there is another option for high risk. If it's low or intermediate risk, it doesn't matter. You're gonna be all right anyway. You're gonna die from something other than prostate cancer, even if you don't have treatment. We know that much already. And then the last controversy for another 2 minutes is follow-up. Once you finish the treatment, and they say, oh, you're discharged, say, no, thank you. I want to be on the survivorship scheme program. I will be followed up for life. It doesn't mean that I'm coming to the clinic and seeing the patients or the doctors or the nurses face to face. No. It just means that somebody who knows what they're talking about is having a look at my PSA once a year. That's it. So if there is any sign of it recurring, they will pick me up in the good time and do something about it. And by God, there's a lot that we can do nowadays. The improvements in technology in testing, like the PSMA PET scan. I wish we never had Brexit, because the waiting times for PET scan are horrendous now, because we don't manufacture a radioisotope in this country. We have to get it from Europe, and it's become a nightmare to get a shipment from Europe because of Brexit. But we're trying. They are doing their best. But the PSMA PET scan will allow us to treat intelligently the recurrence. So if you had the operation the way we do it, and you cleared here, almost always you do the scan, there's nothing recurring here if there is a recurrence. Find the recurrence here or here, somewhere else, because you cleaned it there, but this was there from day one, but it was too small. And after a few years, it showed up. Okay, if it's up to 3 dots, we get Lisa Capaldi and her companions in the radiotherapy with the new radiotherapy machines that we have in Worcestershire, and they do something called stereotactic ablative radiotherapy. In simple language, it's a very highly focused radiotherapy, often only 1 or 2 shots, and highly focused on this dot that you can see on the scan. And then the PSA that went up to 0.7 becomes unrecordable again. You go on for 2-3 years again, and then another dot appears somewhere. We give it another saber. And if they are more than 3, or they are in an area, I don't know, next to the heart or something, you can't irradiate it, then there is loads and loads and loads of new treatments. Not only the injection every 3 months, but there are very new treatments that are less toxic and very effective, even when the injections stop being effective. The bottom line is Lisa and her department will keep you going until you get the telegram from the king. So in a funny way, it's a very good time to have treatment for prostate cancer because of the advances that is happening, but the misinformation are to be resisted. And it's only you who can resist it. When they say to you, oh, come and have a focal therapy. You know what they say? If it sounds too good to be true, then it's not true. Oh, I'll give you focal therapy is you treat a bit of the gland. They say, oh, we are targeting the index tumor, the most aggressive one. How do you know? Oh, done an MRI scan. The MRI scan accuracy is at best 70%. When you look at the database, and one time I'll show you the slides, we operate on the patient thinking that he's got T2, i.e. localized cancer. In 35%, we find that he's got T3. So we use the same MRI they use, but it's wrong in 35% of the time. And we think he's got a bit of tumor on the right lobe. When we take the whole prostate out, we find that he had 5 tumors. 4 of them were on the left lobe. None of the tests is 100% accurate. So to say, oh, I'm going to just pick up this important tumor and we'll watch the rest of the gland. The best term I heard about focal therapy is it's kicking the can down the road. You're just going to delay, lower your PSA a bit more and enjoy your ejaculation and your erection and what have you. Because rather than 50% risk of losing them, it's only 30% risk of losing them. Okay. Your priorities might not be like my priorities, but I respect your opinion. If that's what you want to do, it's a free country, you can do what you want. But what is wrong is to pretend that this is an equivalent treatment to proper radiotherapy or proper surgery. It isn't. It may be equivalent to robotic surgery if you have high-risk disease. I'll stop at that. I do apologize again for being late. I'm very happy to take any questions from anybody.
Thank you very much for the honest approach to obviously a serious subject. It's nice to think that there are people that are so passionate about the work are actually prepared to challenge some of these things. And from my point of view, I haven't had prostate cancer, and I hope I never get it. However, 10 years ago, I had a TURPS operation, which was successful. I was told that I still needed a PSA every year. The first 2 years after that operation, I got my PSA with some problems. I had to really argue that I should have it. After third year, I went down and we were lucky. We had a new GP, a young man, come in, and I said, look, I'd like a PSA done. Not a problem. You can have it done every year. Now, they phone me every year and say, your PSA is due. And I go. So that's good.
Because you live in Worcestershire, which is one of the best places in the country to live in.
Yeah.
Because the GPs are generally, there's always exceptions, are generally very good.
Yeah. And they do that now every year. The other thing is that about challenging people, I think that's very important. I personally had an instance a few years ago now where, nothing to do with prostate or whatever, where I challenged a GP politely, said, look, I'm not happy with this. I would really like this done. That GP then turned to me and said, I feel threatened now. I said, you feel threatened because I'm challenging what you're saying? And I actually invited her, it was a lady, to get another GP in with me. She declined. The next time I went, I took my wife with me as a witness. I have never, ever seen that GP since. I refuse to see it.
I'll give you an anecdote. I run currently, just starting a project with people, black ethnic people from Birmingham and the black country, and they will come to Worcestershire, but we don't have many black people in Worcestershire. And the reason is, culturally, they don't engage with us. They don't come to meetings like this. They don't go to Mary and say, oh, I've got a problem, I need support. And we want to get out and reach out for them. So I'm trying a new thing that women tried for breast cancer, and I'm copying it from them, which is going through a big Nigerian church in Birmingham. And we're going to reach out to them. I think we have a meeting in about 4 or 6 weeks there, where there is apparently 10,000 black ethnicity people from all over the country are going to be attending, and we'll give them a talk to just encourage them to engage with the health services and to get themselves checked, because they get very horrible diseases very young age, and they almost always present very late. And one of the, if you like, people who are helping me with that is a black man from Wolverhampton, very nice man, who is very well educated, and he had himself checked and he found his cancer and got treated and he's fine. But then he contacted his larger family, and they all live in London, South London. They are from the Windrush generation. And his nephew, who was 40-something, a city banker in London, multi-millionaire, very successful guy, and drives a Ferrari. So he was phoning him and said, look, now that your uncle has got this bloody disease, you need to get checked. He said, yeah, I'm only 40. Yeah, because you're black like me, you have to be checked at a younger age, which is true. He said, okay, uncle. So he went down in his Ferrari, and this is not a joke, this is the story after this man told me only a couple of weeks ago. He went down to drive to his GP surgery. So he was stopped by the police because they thought that this black man stole the Ferrari. He tried to convince them that he hasn't stolen the Ferrari, and it was about an hour until he proved to them that it's actually his car. So they let him go. So he was obviously upset. And he thought, okay, I'll just go to the GP and do this. So he went to the GP. The GP said, no, you're not having a PSA, you're too young. So he was exhausted by then after the experience of the day. So went home, opened the bottle of wine and sat to drown his sorrow. So his uncle phoned him again. Have you had the PSA? He said, look, this is what happened to me. He said, okay. Tomorrow, it's Saturday, I'm coming tomorrow. So he went to his nephew, took him by his hand, went to the nearest A&E department, told them, you're all bloody racist. You do PSA and A&E, what are you talking about? We're not walking away until you do a PSA on my nephew. Anyway, they did the PSA, and the PSA was 8. In a 40-year-old young man with no other health issues. So he went to the private hospital straight away. He's a multimillionaire, the guy, and got himself checked out, and he had Gleason 10 disease, T3, at the age of 40. So quickly, he had his treatment privately in London, and then the letter went to the GP. So the GP was like, bloody hell. So he phoned them, and they told him, I'm very, very sorry. I didn't know that it can happen at this young age. I don't think the GPs are just being awkward. I think genuinely they are not being guided properly, not least because of what Nice is saying.
Right. Anybody else got a question?
Mr. Makar, I'm your Irish man.
Hello. You're not Irish, you're sober.
And I want to thank you for removing my prostate 11 years ago. I've been on the survivorship program with a reading of 000 for that time now. But 2 weeks ago I had a call from Redditch saying, oh, you've got a reading now of 0.1. Mr. Makar says, do it every 3 months now instead of a year. And when it reaches 0.3, we'll refer you to Mr. Makar for further treatment.
I haven't paid them to say that. This is exactly what I was talking about. No one will be lost. How many years ago your operation was?
11.
There you go. 11 years ago, we're still following him up, and his PSA, if it goes to any GP, to any urologist, anywhere, at 0.1, it's normal. They say, well, nothing to worry about. It isn't normal. It may be, but it should be less than 0.1. So once it becomes 0.1, rather than having the PSA every year as you were having it done, now we go down to more frequent PSAs.
3 months.
Because if it goes up to 0.2 or above, then there may be some recurrence, but there may not be. But then we can, after it goes to 0.3, we can do the PSMA PET scan if they can get the stuff from Europe. And then if we found it, we could give you one of these very high dose, very focally localized SABR radiotherapy. And you will be here until you get will you get, if being Irish, will you get a telegram from the king? I'm just, this is why I do what I do, because this for me, I'm made up now.
Thank you, Mr. Makar.
Hello. I have a question about post-operative continence, or incontinence, as it were. It's not very often talked about, and you never find solutions being offered to resolve it.
We are doing it.
So let's talk 1 minute about continence or lack of. If you ask everybody in the room, men and women, those who had prostate trouble and those who didn't, those who had operation and those who didn't, and say them hand on heart, do you ever drop a drop or two like that? Stains the underwear and that's it. You don't tell anybody. All of us do it. That the system is not 100% accurate. But we don't even think about it because we don't think there's anything wrong with us. Once you're told you have a prostate cancer and you had an operation or you had a radiotherapy, you're looking in any twitch in your eye, you're looking in any change in the color of your hands, you're looking in anything down in the pants. That's normal. So you become more aware of things that normally you would have ignored. That doesn't mean that incontinence is not a problem after these treatments. It is. But in a large proportion of patients, it is a problem because they notice it more than others do. However, that's why the definition of incontinence is very important. So we call it social incontinence, i.e. if you sat there and the people around you are getting away because you smell. That's incontinence. You wet, it's the patch that everybody can see, and you smell. Incontinence is not an odd drop here and there. And that's difficult to capture objectively. So we tend to say if you have more than one pad a day, and a small pad that is sometimes a bit damp rather than soaking wet, then you're not socially incontinent. Now, if you were to have surgery, irrespective whether it's open or robotic, at least 50 to 60% of men are incontinent immediately after the operation. And with pelvic floor exercise, this 50 to 60% keeps dropping every few weeks. If you look at them at 1 year, and we did that even 10 years, there's less than 5% who are still wearing more than one pad a day, i.e. socially incontinent. If they are socially incontinent and wearing them more than one pad and smelly and wet, there are various treatments, but the first thing to do is to characterize this incontinence. So there's lots of women who have incontinence and wearing pads, but they don't have prostates and never had operation for the prostate. So it's important to identify the type of incontinence. Is it urgency incontinence due to overactive bladder, which has nothing to do with the prostate or the prostate operation? And the treatment is to dampen the bladder overactivity with drugs or Botox injections or operations, as opposed to those who have stress incontinence, i.e. to cough or sneeze or lift a heavy object and then the floodgates open. in which case this is to be treated by enhancing the strength of the sphincter, and if you can't, very rare cases, you could have either a sling or an artificial sphincter. I have to say, looking at the last consecutive 1,000 cases that we've done in Worcestershire, not a single one of them required an artificial sphincter. But yeah, there are various treatments for it. The first step is always pelvic floor exercise. Now, having criticized, nice enough, and the NHS, they actually have now an app on the phone, NHS app, called the Squeezy app. You get it from your app store on the phone, download it, and it reminds you when to do the pelvic floor exercise, how to do it, and it's fantastic. I found it very helpful to my patients.
One more, please, and then we'll... oh, Peter. Okay, then.
Thanks very much indeed. Hello, Adel. I got a question, really. We, in the group, we've gone back last year to PSA testing in the community, and we're doing 2 lots of testing. We've just done one in Pershore, 160 odd men, and Kidderminster in September with over 200. That doesn't meet with universal approval, even within TACL. Sorry?
What is TACL?
TACL is the federation of all the 130 prostate cancer support groups in the UK. Right, okay. But what I'm asking, I mean, and what we're trying to do also is to try and get down to the, you talked about the black community. We're trying to also get to the hard-to-reach community, and that's by getting in touch with companies, with engineering companies, whatever. I just wondered really how you regard today's PSA community testing, mainly done by the Graham Fulford Trust, whether it's something that you would urge us to continue with, or whether you have your doubts about. Thanks.
So long as the man is informed, he's not having it by chance. So if the man is going to have a blood test for his liver function or kidney function, and then the GP or the urologist or the nurse adds the PSA without telling him, that's wrong. I think if the man is informed and he wants the PSA to be done, this is the guidance. So nobody can criticize that. I'm very supportive of this continuing in the community, provided that it's not just a blood test, it's just information as well. So there is an information leaflet. The people who are having their PSA checks sit in meetings like that, they are aware what they're doing. Because what I didn't tell you is, in the last 1,000 consecutive operations we've done, not a single one died within 3 months from the operation because of complications of the operation. But this is not the same everywhere. There are people who can die from a biopsy. Were reported sepsis and death. So you can't put a man through something like that without him knowing what the implications are. But once he knows the implications and he's willing, and he's coming to you, let's face it, you didn't go to him at home and pull the, no, he's coming to you requesting the test. There's nothing wrong with that. I know that it's not universally supported, but until there is a screening program in the country, these things will keep popping up every now and again. The good news is there is a trial for screening that is about to start. And I'm invited to take part in it, and I will make my mind up whether the trial, the basics of the trial, the methodology is good or not. Because the worst thing to do is to start an experiment with the wrong methodology, and then you'll be hostage to the wrong answer. Because if you did the wrong methodology, you'll have the wrong answer, but you'll be hostage to it because that's evidence that you have to respect. So it's important to set the trial on the right path from day one. We're trying to do that now.
Thank you very much. Can't thank you enough for coming tonight. Will everybody say thank you to Sister Makar?